Diarrhea is defined as the frequent passage of loose or watery stools. It occurs when intestinal contents move through the gastrointestinal tract too quickly, which prevents the large intestine from absorbing enough water and electrolytes. Because of this rapid movement, the stool becomes watery and patients may lose significant amounts of fluid. Common causes of diarrhea include infections, food intolerances, inflammatory bowel disorders, medications such as antibiotics or laxatives, and emotional stress. Patients often report abdominal cramping, bloating, urgency to defecate, and fatigue. In severe cases, diarrhea can lead to dehydration and electrolyte imbalance, which are important complications nurses must monitor closely. From a nursing perspective, assessment focuses on stool frequency, consistency, and color, as well as monitoring fluid intake and output. Nurses should assess for signs of dehydration, such as dry mucous membranes, decreased urine output, dizziness, or tachycardia. The perianal skin must also be monitored carefully because frequent stools can cause irritation or breakdown. Treatment usually focuses on treating the underlying cause and maintaining hydration. Patients may receive anti-diarrheal medications, fluid replacement, and dietary modifications. Patient education is important, including drinking adequate fluids, avoiding trigger foods, and recognizing when symptoms require medical attention. Constipation occurs when bowel movements become infrequent, difficult to pass, or associated with hard, dry stools. It usually develops when stool moves slowly through the large intestine, allowing too much water to be absorbed from the fecal material. Several factors can contribute to constipation. The most common causes include insufficient fluid intake, a low-fiber diet, decreased physical activity, medications such as opioids or anticholinergics, and prolonged bed rest. Constipation may also be associated with underlying medical conditions such as bowel obstruction, hypothyroidism, or colorectal disease. Patients experiencing constipation may report abdominal discomfort, bloating, decreased appetite, and straining during bowel movements. Chronic constipation can increase the risk for hemorrhoids, fecal impaction, or bowel obstruction if it is not properly managed. Nursing care begins with a thorough health assessment and focused gastrointestinal assessment, including evaluation of bowel patterns, stool characteristics, dietary habits, hydration status, and physical activity level. Treatment often includes increasing dietary fiber, encouraging adequate fluid intake, promoting physical activity, and administering medications such as stool softeners or bulk-forming agents when prescribed. Patient education is an important part of prevention. Teaching patients to maintain adequate hydration, eat fiber-rich foods, remain physically active, and avoid excessive straining during bowel movements can help promote healthy bowel function. Irritable bowel syndrome, commonly called IBS, is a functional gastrointestinal disorder that affects bowel motility. A functional disorder means that the digestive tract does not work normally, but no structural disease or visible damage to the intestines is present. IBS is very common. In the United States alone, an estimated 25 to 45 million people are affected, and it occurs more frequently in women than in men. Most individuals diagnosed with IBS are younger than 50 years of age. The exact cause of IBS is not fully understood, but current research suggests that it involves a combination of intestinal hypersensitivity, abnormal motility, and communication problems between the brain and the gastrointestinal tract. This communication pathway is called the brain-gut axis, which is a two-way biochemical signaling system linking the central nervous system and the digestive tract. Because of this connection, stress, emotional factors, and psychological conditions can significantly influence gastrointestinal symptoms. Some patients also have a family history of IBS, suggesting a possible genetic or familial predisposition. Certain triggers can worsen symptoms in susceptible individuals. These triggers may include stress, caffeine, and specific foods such as dairy products or wheat-based foods. For some patients, symptoms may appear after a gastrointestinal infection, which may alter the intestinal lining or disrupt the normal intestinal bacteria, also known as the gut microbiota. The pathophysiology of IBS involves abnormal intestinal motility and increased sensitivity of the intestinal nerves. Patients often experience altered bowel patterns, abdominal pain, and bloating due to irregular contractions of the intestines. Some individuals experience IBS with constipation, others have IBS with diarrhea, and some have alternating constipation and diarrhea. One important neurotransmitter involved in intestinal function is serotonin, also called 5-hydroxytryptamine or 5-HT. Serotonin plays a role in regulating bowel motility, secretion, and visceral sensitivity, and medications that affect serotonin receptors are sometimes used in treatment. The three hallmark characteristics of IBS include changes in bowel elimination patterns, abdominal pain with bloating, and the absence of identifiable organic disease. Patients frequently report abdominal discomfort that improves after a bowel movement, along with excess gas production and bloating. Each patient often develops a unique pattern of symptoms, which can vary in severity and frequency. Diagnosis of IBS is primarily clinical, meaning it is based on patient history and symptoms rather than laboratory or imaging tests. Healthcare providers must first rule out other gastrointestinal diseases such as inflammatory bowel disease, colorectal cancer, or infection. Diagnostic indicators include abdominal pain that is relieved by defecation, changes in stool frequency or consistency, mucus in the stool, and abdominal bloating. However, if certain alarm features are present, such as unintentional weight loss, iron deficiency anemia, or a family history of serious gastrointestinal disease, additional diagnostic testing is necessary to rule out other conditions. Treatment of IBS focuses on symptom management and improving quality of life. There is currently no cure, so therapy aims to control symptoms such as diarrhea, constipation, bloating, and abdominal discomfort. Nurses play a key role in providing reassurance, education, and support because IBS can significantly affect a patient's daily functioning and emotional well-being. Diet modification is an important treatment strategy. Some patients find relief by avoiding foods that trigger symptoms, including gluten-containing foods, dairy products, caffeine, or gas-producing foods. Patients may benefit from keeping a food diary to identify patterns between diet and symptoms. Because symptoms can sometimes appear several days after a trigger food is eaten, maintaining a diary for several weeks can help identify problem foods. Medications may also be prescribed depending on the patient's symptoms. These medications may include antidiarrheal agents, laxatives or stool softeners, antispasmodics to reduce intestinal cramping, or medications that affect serotonin receptors to regulate motility. Psychological therapies can also be beneficial because of the strong connection between stress and bowel function. Cognitive behavioral therapy, psychotherapy, and hypnotherapy have been shown in clinical trials to help improve overall symptoms and coping abilities in some patients. In certain cases, consultation with mental health specialists or psychiatric nursing professionals can help patients develop effective coping strategies for stress. During assessment, nurses should collect detailed information about the patient's symptom history, bowel patterns, abdominal pain characteristics, dietary triggers, stress levels, and coping methods. The physical examination includes assessment of bowel sounds, abdominal tenderness, abdominal firmness, and stool characteristics. This comprehensive assessment helps identify symptom patterns and rule out more serious conditions. Some patients also explore complementary therapies, such as peppermint oil. Peppermint oil may help relax intestinal smooth muscle and reduce abdominal discomfort in some patients with IBS. However, patients who have gastroesophageal reflux disease, or GERD, should avoid peppermint oil because it can relax the lower esophageal sphincter and worsen heartburn, especially in patients taking acid-reducing medications. Diverticulosis refers to the presence of diverticula, which are small pouch-like outpouchings that develop when the mucous membrane pushes through weak areas in the muscular wall of the intestine. These pouches are found most often in the colon, especially in older adults. Diverticulosis becomes more common with age and is often seen in patients who have a history of chronic constipation, straining with bowel movements, obesity, or a low-fiber diet. Increased pressure inside the bowel over time is thought to contribute to the formation of these pouches. Many patients with diverticulosis have no symptoms at all, and the condition may be found incidentally during diagnostic testing for another problem. When symptoms do occur, they may be mild and may include a history of constipation, abdominal discomfort, or occasional rectal bleeding. Because diverticulosis itself is usually not inflamed, patients often do not have fever or severe pain unless the condition progresses to diverticulitis. Treatment for diverticulosis is usually conservative and focuses on preventing constipation and reducing pressure in the colon. Patients are commonly instructed to eat a high-fiber diet, increase fluid intake, and maintain regular activity or exercise. Foods such as whole grains, fruits, vegetables, beans, and lentils help increase stool bulk and improve bowel regularity. Stool softeners or bulk-forming agents may also be recommended when prescribed. As LPN nurses, an important role is reinforcing teaching about fiber, hydration, exercise, and healthy bowel habits to help prevent complications. Diverticulitis occurs when one or more diverticula become inflamed or infected. This usually happens when food particles or fecal material become trapped in the pouch, allowing bacteria to grow and irritate the intestinal wall. As the infection or inflammation worsens, the wall of the bowel can become swollen and fragile. If not treated promptly, diverticulitis can lead to serious complications such as abscess formation, intestinal obstruction, perforation, or peritonitis. Patients with diverticulitis commonly develop acute left lower abdominal pain, which is one of the most important findings. They may also have bloating, nausea, vomiting, diarrhea, or constipation, and sometimes fever. In more severe cases, there may be rectal bleeding. If bleeding becomes significant, the patient may develop hypotension and signs of shock. LPN nurses should recognize that worsening abdominal pain, fever, abdominal rigidity, or signs of sepsis may indicate a medical emergency. The preferred diagnostic test for suspected diverticulitis is a computed tomography scan of the abdomen, often with water-soluble contrast. This helps confirm the diagnosis and also helps rule out other abdominal conditions. During an acute episode, colonoscopy and barium enema are usually avoided because they can increase the risk of bowel perforation. Treatment depends on the severity of the condition. Mild, uncomplicated diverticulitis may sometimes be treated on an outpatient basis with diet modification, oral antibiotics when prescribed, fluids, and pain management. More serious or complicated cases may require nothing by mouth status, intravenous fluids, intravenous antibiotics, bowel rest, and close monitoring. Recurrent diverticulitis or complications such as perforation, fistula, obstruction, or unresolved abscess may require surgery to remove the diseased section of bowel. Some patients may need a temporary or permanent colostomy depending on the extent of disease and the surgical findings. From a nursing perspective, care includes monitoring pain, bowel function, vital signs, hydration status, and signs of complications. Patient teaching should emphasize diet, adequate fluid intake, physical activity, and when to seek immediate medical care. An intestinal obstruction occurs when there is a partial or complete blockage in the intestinal tract that prevents the normal movement of gastrointestinal contents. This blockage can occur suddenly or develop gradually over time. Because the intestine is responsible for moving food, fluid, and waste through the digestive system, any obstruction can significantly disrupt digestion and fluid balance. If an intestinal obstruction is not treated promptly, it can lead to serious complications. Increased pressure in the intestine can reduce blood flow to the bowel, which may result in bowel ischemia, meaning the intestinal tissue does not receive enough oxygen. If the bowel wall becomes damaged, perforation may occur, allowing intestinal contents and bacteria to leak into the abdominal cavity. This can cause peritonitis, sepsis, and life-threatening infection. Because of these risks, intestinal obstruction is considered a medical emergency requiring rapid assessment and treatment. There are two main categories of intestinal obstruction: mechanical and non-mechanical. A mechanical obstruction occurs when something physically blocks the intestinal lumen, which is the inside passageway of the bowel. Several conditions can cause this type of obstruction. The most common cause is adhesions, which are bands of scar tissue that develop after abdominal surgery, trauma, or inflammation. These fibrous bands can cause loops of bowel to stick together or become kinked. Other causes of mechanical obstruction include tumors, strangulated hernias, twisting of the bowel called volvulus, telescoping of one section of bowel into another called intussusception, foreign bodies, and scarring from radiation therapy. A non-mechanical obstruction, also called a functional obstruction, occurs when the intestine stops moving contents forward because normal peristalsis is absent or severely decreased. This condition is commonly called paralytic ileus. A non-mechanical obstruction, or paralytic ileus, occurs when the intestine fails to move its contents forward because the normal wave-like contractions called peristalsis stop functioning. Paralytic ileus commonly occurs after abdominal surgery, because bowel manipulation during surgery temporarily decreases intestinal motility. However, other conditions may also contribute to paralytic ileus. These include infection, electrolyte imbalances such as hypokalemia, reduced blood flow to the intestines, kidney disease, and medications that slow intestinal movement. One of the most common medication causes is opioid pain medications, which decrease gastrointestinal motility and may lead to delayed bowel function after surgery. When an obstruction occurs, fluid, gas, and intestinal contents accumulate above the blockage. As these contents build up, the intestine becomes distended, and pressure inside the bowel increases. The intestine initially attempts to push material past the obstruction by increasing peristaltic contractions above the blockage. These strong contractions often cause severe cramping abdominal pain. As pressure continues to increase, fluid shifts from the bloodstream into the intestinal lumen. This can cause dehydration and electrolyte imbalance. If the pressure becomes severe enough, it can reduce blood supply to the intestinal wall. This may result in bowel tissue necrosis, perforation, and life-threatening infection. The symptoms of intestinal obstruction vary depending on where the blockage occurs. When the obstruction occurs high in the small intestine, symptoms usually appear suddenly. Patients may experience sharp upper abdominal pain, frequent vomiting, and rapid dehydration. Because the blockage is higher in the digestive tract, there is usually less abdominal distension. In contrast, large intestine obstructions tend to develop more gradually. Patients often experience significant abdominal distension, prolonged abdominal pain associated with peristaltic waves, and delayed vomiting. In severe cases, the vomitus may have a fecal odor, which suggests a complete intestinal obstruction. Diagnosis of intestinal obstruction typically begins with imaging studies. An abdominal X-ray may show dilated bowel loops or air fluid levels that suggest obstruction. A CT scan is frequently used because it can more accurately identify the location and cause of the obstruction and detect complications, such as ischemia or perforation. Initial treatment focuses on stabilizing the patient and relieving pressure in the intestine. A nasogastric tube may be inserted to remove gas, fluid, and intestinal contents, which helps reduce vomiting and abdominal distension. Patients also receive intravenous fluids and electrolyte replacement. If the obstruction cannot be relieved with decompression, or if complications develop, surgery may be necessary. Surgical treatment may involve cutting adhesions, repairing a hernia, untwisting a volvulus, or removing a tumor or a damaged section of bowel. Nursing management focuses on careful monitoring and prevention of complications. Positioning the patient in a Fowler position with the head of the bed elevated helps reduce abdominal pressure and allows gas and intestinal contents to drain more effectively through decompression tubes. Nurses must closely monitor fluid and electrolyte balance because vomiting and fluid shifts into the bowel can quickly lead to dehydration. Another important nursing intervention is measuring abdominal girth regularly, usually every 2 to 4 hours, at the same location each time to monitor worsening distension. Pain management is important. However, nurses must be alert for increasing or persistent severe pain, which may indicate bowel ischemia, perforation, or worsening obstruction. These complications require immediate medical evaluation. A hernia occurs when an internal structure, most commonly part of the intestine or fatty tissue, pushes through a weak area in the muscle or connective tissue wall that normally contains it. This weakness allows tissue to bulge outward, forming a visible or palpable swelling. Hernias most commonly occur in areas where the abdominal wall is naturally thinner or has been weakened over time. Common locations include the umbilicus, previous surgical incision sites, the inguinal region in the groin, and the femoral canal. Hernias may be congenital, meaning they are present at birth due to incomplete closure of abdominal structures, or acquired, meaning they develop later in life as a result of muscle weakness or increased abdominal pressure. Several factors increase the risk of developing a hernia. Most of these factors involve increased intra-abdominal pressure or weakening of the abdominal wall. Common risk factors include heavy lifting, chronic coughing, straining during bowel movements or urination, obesity, pregnancy, ascites, and prior abdominal surgery. These conditions increase pressure within the abdomen and may gradually weaken the supporting muscles. Inguinal hernias occur more frequently in males, partly due to anatomical differences in the inguinal canal. Femoral hernias are less common but are considered more dangerous because they have a higher risk of becoming strangulated. Ventral hernias occur along the front of the abdominal wall. These include umbilical hernias near the navel, epigastric hernias in the upper abdomen, and incisional hernias that develop at previous surgical incision sites. Groin hernias include inguinal and femoral hernias. Inguinal hernias occur in the inguinal canal and are the most common type. Femoral hernias occur slightly lower in the femoral canal and are more common in women, though they are less frequent overall. Hernias are also classified based on whether the protruding tissue can be returned to the abdomen. A reducible hernia can be gently pushed back into the abdominal cavity or may flatten when the patient lies down. An incarcerated hernia occurs when the protruding tissue becomes trapped outside the abdominal wall and cannot be reduced. A strangulated hernia is the most serious type. In this situation, the blood supply to the trapped tissue becomes compromised. Without blood flow, the tissue can quickly develop ischemia and tissue death. Strangulated hernias require emergency surgical treatment. Many uncomplicated hernias appear as a visible or palpable bulge in the abdomen or groin. This bulge often becomes more noticeable when the patient coughs, strains, stands, or lifts heavy objects because these actions increase abdominal pressure. The bulge may become smaller or disappear when the patient lies down, especially if the hernia is reducible. Some patients experience pressure, heaviness, burning, or mild aching rather than severe pain. However, pain that becomes sudden, severe, or persistent may indicate that the hernia has become incarcerated or strangulated. Certain symptoms suggest that a hernia has become incarcerated or strangulated, which requires urgent medical evaluation. Warning signs include a painful, firm hernia that cannot be pushed back into the abdomen, especially if it is accompanied by nausea, vomiting, abdominal distension, or skin redness over the hernia. When intestinal tissue becomes trapped, the patient may develop bowel obstruction symptoms, including abdominal pain, vomiting, and inability to pass stool or gas. These symptoms indicate that blood flow to the bowel may be reduced and immediate medical attention is required. The definitive treatment for most hernias is surgical repair. The goal of surgery is to return the protruding tissue to its normal position and strengthen the weakened abdominal wall. In a herniorrhaphy, the defect is repaired by closing the opening with sutures. In a hernioplasty, the weakened area is reinforced with a surgical mesh. Mesh reinforcement is widely used because it can reduce recurrence rates, although patients should discuss potential risks and benefits with their surgeon. Hernia repair may be performed using open surgery or laparoscopic techniques, and many uncomplicated repairs can be completed as outpatient procedures. After hernia repair surgery, nursing care focuses on pain control, incision care, and monitoring for complications. Patients are typically instructed to avoid heavy lifting, pushing, pulling, or straining during the healing period to prevent recurrence. They should also be taught to support the incision when coughing or sneezing, which helps reduce strain on the surgical site. Stool softeners may be prescribed to prevent constipation and reduce straining during bowel movements. Patients should report fever, redness, drainage, increasing swelling, worsening pain, persistent vomiting, or inability to pass stool or gas because these symptoms may indicate infection or postoperative complications. Bowel ischemia occurs when blood flow to the intestines becomes insufficient to meet the metabolic needs of intestinal tissues. Blood carries oxygen and nutrients that are necessary for tissue survival. When the blood supply is reduced or blocked, the intestinal tissue can become damaged. Bowel ischemia may develop suddenly, which is called acute bowel ischemia, or gradually over time as a chronic condition. Acute bowel ischemia is considered a medical emergency because prolonged lack of blood flow can cause intestinal tissue to die. If untreated, bowel ischemia can lead to intestinal necrosis, perforation of the bowel wall, peritonitis, sepsis, and death. Because of these severe complications, early recognition and treatment are critical. Bowel ischemia is often classified based on which part of the intestine is affected. When ischemia occurs in the small intestine, it is called mesenteric ischemia because the mesenteric arteries supply blood to the small intestine. When ischemia affects the large intestine, the condition is called colonic ischemia. Although chronic forms can occur, most cases of bowel ischemia develop suddenly as acute mesenteric ischemia. This often happens when a blood clot or embolus blocks a blood vessel supplying the intestines. Several conditions can reduce blood flow to the intestines. One cause is embolism, which occurs when a blood clot or debris travels through the bloodstream and becomes lodged in a vessel supplying the intestines. Another cause is thrombosis, which occurs when a clot forms directly within a blood vessel and gradually blocks circulation. Over time, atherosclerosis, which is the buildup of fatty plaques within arteries, can narrow the vessels supplying the intestines and reduce blood flow. Bowel ischemia can also occur when overall circulation decreases, such as in hypotension, hypovolemic shock, severe infection, or organ failure. During these conditions, the body prioritizes blood flow to vital organs such as the brain, heart, lungs, and kidneys, which can reduce blood flow to the intestines. The symptoms of bowel ischemia can resemble many other abdominal conditions, so careful assessment is very important. The most common symptom of acute bowel ischemia is sudden, severe abdominal pain. Early in the condition, the pain may appear out of proportion to physical examination findings, meaning the patient reports severe pain even though the abdomen may initially appear relatively normal. Patients may also experience nausea, vomiting, diarrhea, and abdominal cramping. As the condition worsens, the abdomen may become tender to palpation, and the patient may develop guarding, which is a protective tightening of the abdominal muscles due to pain. Bowel sounds may become minimal or absent because the intestines are no longer functioning normally. Laboratory tests and imaging studies are used to help diagnose bowel ischemia. A white blood cell count is often elevated, which indicates inflammation or infection. However, imaging studies are essential to confirm the diagnosis. Two common tests are computed tomography angiography, or CTA, and magnetic resonance angiography, or MRA. These imaging studies allow healthcare providers to visualize the blood vessels supplying the intestines and identify areas where blood flow is reduced or blocked. Treatment of bowel ischemia focuses on restoring blood flow and preventing further intestinal damage. Initially, the patient is placed on nothing by mouth status, or NPO, to allow the gastrointestinal tract to rest. A nasogastric tube may be inserted to remove gas and fluids from the stomach and intestines, which helps reduce vomiting and abdominal distension. Patients also receive intravenous fluids to maintain circulation and hydration. If the ischemia is caused by a blood clot, treatment may include anticoagulant medications such as intravenous heparin, which helps prevent further clot formation. In some cases, thrombolytic medications may be used to dissolve the clot. A Foley catheter may be inserted to monitor urine output, which helps healthcare providers assess kidney perfusion and overall fluid status. If blood flow cannot be restored quickly, or if intestinal tissue has already become necrotic, meaning the tissue has died due to lack of oxygen, surgery may be necessary. During surgery, the surgeon may remove the damaged portion of the intestine and attempt to restore circulation to the remaining bowel. Because bowel ischemia can progress rapidly to life-threatening complications, early recognition and treatment are extremely important. Nurses play an important role in monitoring patients with bowel ischemia. Key assessments include monitoring abdominal pain, abdominal distension, bowel sounds, vital signs, and urine output. These findings help identify changes in the patient's condition. Any worsening pain, increasing abdominal distension, changes in vital signs, or decreased urine output should be reported immediately because these symptoms may indicate worsening ischemia or complications. Prompt recognition and communication with the healthcare team are essential for preventing serious complications and improving patient outcomes. Inflammatory bowel disease, commonly called IBD, is a broad term used to describe two major chronic inflammatory conditions of the gastrointestinal tract: ulcerative colitis and Crohn's disease. Although these diseases share some symptoms, they are not the same disorder. Both conditions involve inflammation of the digestive tract and typically follow a pattern of flares and remission. During a flare, symptoms worsen and inflammation increases. During remission, symptoms may improve or temporarily disappear. Understanding the difference between these two conditions is important for nurses because the location of inflammation, complications, and treatment approaches can vary. Ulcerative colitis primarily affects the large intestine, including the colon and rectum. In this condition, inflammation spreads in a continuous pattern along the bowel, meaning there are no normal areas between inflamed sections. The inflammation mainly affects the mucosal lining of the colon, which is the inner surface of the bowel. Because the lining becomes inflamed, fragile, and ulcerated, patients often experience bloody diarrhea, rectal bleeding, abdominal cramping, and an urgent need to have bowel movements. Crohn's disease differs from ulcerative colitis in several important ways. Crohn's disease can affect any part of the gastrointestinal tract from the mouth to the anus, although it most commonly involves the distal small intestine and the beginning of the colon. Unlike ulcerative colitis, inflammation in Crohn's disease occurs in patches, leaving normal sections of bowel between diseased areas. These areas are called skip lesions. Another key difference is that Crohn's disease affects the entire thickness of the bowel wall, which can lead to complications such as narrowing of the bowel, fistulas, fissures, and perianal disease. The exact cause of inflammatory bowel disease is not fully understood, which means the condition is considered idiopathic. Research suggests that several factors may contribute to the development of IBD. These include genetic susceptibility, immune system dysfunction, and environmental triggers. Family history increases the likelihood of developing these conditions. Smoking is associated with a higher risk of Crohn's disease, although it is not recommended as a preventive measure for ulcerative colitis. While stress does not directly cause inflammatory bowel disease, it can worsen symptoms and trigger flare-ups in some patients. Both ulcerative colitis and Crohn's disease often occur in cycles of flare-ups and remission. During a flare, patients may experience frequent diarrhea, abdominal cramping, fatigue, fever, decreased appetite, and weight loss. Because diarrhea can be severe and frequent, patients are at risk for fluid volume deficit, electrolyte imbalance, anemia, and malnutrition. Nurses must monitor these patients closely for signs of dehydration and nutritional deficiencies. The complications of ulcerative colitis and Crohn's disease differ because of how each disease affects the bowel. In ulcerative colitis, complications may include severe bleeding, toxic megacolon, and an increased risk of colorectal cancer, especially with long-standing disease. In Crohn's disease, complications are more likely to include bowel obstruction, fistulas, abscesses, anal fissures, and malabsorption, particularly when the small intestine is involved. Understanding these differences helps nurses recognize potential complications early. Diagnosis of inflammatory bowel disease requires a combination of patient history, physical assessment, laboratory tests, and visualization of the bowel. Healthcare providers commonly use colonoscopy with biopsy to directly examine the colon and obtain tissue samples. Additional tests may include flexible sigmoidoscopy, blood tests, and stool tests to help confirm the diagnosis and rule out infections or other gastrointestinal disorders. Patients often present with chronic symptoms that may initially be mistaken for infection or irritable bowel syndrome, so careful history taking is essential. Treatment of inflammatory bowel disease focuses on reducing inflammation, controlling symptoms, maintaining remission, and preventing complications. Several types of medications may be used. These include aminosalicylates to reduce inflammation, corticosteroids for acute flares, immunomodulators to regulate the immune response, and biologic therapies that target specific inflammatory pathways such as tumor necrosis factor. The choice of treatment depends on the type of disease, severity of symptoms, and patient response to therapy. Surgery may be necessary when disease is severe, complications develop, or medications do not control symptoms. In ulcerative colitis, surgery to remove the colon and rectum can eliminate the diseased tissue and may be curative for the colonic disease. In Crohn's disease, surgery may help treat complications such as obstruction, fistulas, or abscesses, but it does not cure the disease because inflammation can return in other parts of the gastrointestinal tract. Nursing care for patients with inflammatory bowel disease focuses on careful assessment, symptom monitoring, and patient education. During an acute flare, nurses monitor stool frequency and characteristics, abdominal pain, bowel sounds, vital signs, intake and output, daily weight, and laboratory values related to anemia and electrolyte balance. Nutrition is also an important concern. Many patients tolerate small, frequent meals better than large meals, and temporary dietary modifications may be needed during flares. Teaching should emphasize medication adherence, maintaining hydration, recognizing worsening symptoms, and the importance of ongoing follow-up care. Emotional support is also important because inflammatory bowel disease can significantly affect quality of life, work, school, and social activities. Appendicitis is inflammation of the appendix, which is a small, narrow pouch that extends from the cecum at the beginning of the large intestine. Because the appendix has a very narrow opening, it can easily become blocked. When blockage occurs, bacteria multiply inside the appendix, leading to infection, inflammation, and increased pressure. If appendicitis is not treated promptly, the appendix may rupture, allowing infected material to spill into the abdominal cavity. This can lead to peritonitis, a serious infection of the lining of the abdomen that can be life-threatening. The most common cause of appendicitis is obstruction of the appendix lumen, which is the internal opening of the appendix. This blockage may be caused by fecal material called a fecalith, swelling of lymphoid tissue during infection, parasites, or in rare cases, tumors. When the appendix becomes blocked, mucus continues to accumulate inside the organ, increasing pressure. This pressure reduces blood circulation and promotes bacterial growth, causing the appendix to become swollen and filled with pus. If the pressure continues to increase, the appendix may rupture, releasing bacteria into the abdominal cavity. One of the most classic symptoms of appendicitis is pain located in the right lower quadrant of the abdomen near McBurney Point. McBurney Point is located approximately halfway between the umbilicus and the right iliac crest. However, early in appendicitis, patients often experience diffuse abdominal pain near the umbilicus. As the inflammation progresses, the pain typically migrates to the right lower quadrant. Patients commonly report loss of appetite, nausea, vomiting, and a mild fever. The temperature elevation is usually mild in the early stages. During assessment, patients often exhibit abdominal tenderness and muscle guarding. Guarding occurs when the abdominal muscles tighten involuntarily in response to inflammation and pain. Some patients may also position themselves with the right leg flexed because extending the leg stretches the abdominal muscles and increases discomfort. Recognizing these physical findings helps nurses identify possible appendicitis early. The standard treatment for appendicitis is surgical removal of the appendix, called an appendectomy. The procedure may be performed using laparoscopic surgery, which uses small incisions and specialized instruments, or open abdominal surgery if complications such as rupture occur. Before surgery, the patient is placed on nothing by mouth status to prevent aspiration during anesthesia. Patients also receive intravenous fluids and antibiotics to help control infection. A very important safety rule is that laxatives and enemas should never be given when appendicitis is suspected. Increasing bowel activity can raise pressure in the appendix and increase the risk of rupture. Another critical teaching point is that heat should never be applied to the abdomen in suspected appendicitis. Heat increases blood flow and may accelerate inflammation. Instead, a cold compress or ice bag may be used to reduce inflammation and discomfort while awaiting medical evaluation. After surgery, patients who undergo laparoscopic appendectomy often recover quickly and may be discharged the same day. Most patients return to normal activities within 1 to 2 weeks. Patients who require open abdominal surgery may need a longer recovery period, typically 2 to 4 weeks. Nursing care includes monitoring incision sites, pain level, temperature, bowel function, and signs of infection. Early ambulation is encouraged because it helps prevent complications such as atelectasis and venous thromboembolism. Older adults may present differently with appendicitis compared with younger patients. Instead of classic symptoms such as abdominal rigidity and localized pain, older adults may have vague abdominal discomfort, weakness, malaise, or confusion. Because symptoms are less obvious, diagnosis may be delayed, which increases the risk of appendix rupture and serious complications. For this reason, nurses should maintain a high level of suspicion when older adults present with unexplained abdominal pain or sudden decline in condition. Peritonitis most commonly occurs when an abdominal organ ruptures or becomes perforated. allowing bacteria and intestinal contents to enter the abdominal cavity. Examples include a ruptured appendix, perforated gastric or duodenal ulcer, diverticulitis with perforation, or traumatic injury to abdominal organs such as the colon, spleen, or liver. Patients receiving peritoneal dialysis are also at risk because microorganisms can enter the abdominal cavity through the dialysis catheter. Another form is spontaneous bacterial peritonitis, which occurs in patients with cirrhosis and ascites when bacteria move from the intestines into the fluid within the abdominal cavity. Peritonitis is inflammation of the peritoneum, which is the thin membrane that lines the abdominal cavity and covers the abdominal organs. The peritoneum normally helps protect abdominal organs and provides lubrication so organs can move smoothly during digestion. Peritonitis develops when bacteria, digestive fluids, or other irritating substances enter the abdominal cavity. When this occurs, the peritoneum becomes inflamed and infected. This condition is considered a medical emergency because infection can spread quickly through the abdominal cavity and into the bloodstream. If untreated, peritonitis can lead to sepsis, shock, and organ failure. When the peritoneum becomes inflamed, the body responds by increasing blood flow to the affected area. This causes redness, swelling, and release of inflammatory fluid into the abdominal cavity. As bacteria multiply, the fluid may become purulent, meaning it contains pus. Inflammation also affects intestinal function. The intestines may slow down or stop moving completely, a condition known as paralytic ileus. When intestinal motility stops, intestinal contents cannot move normally, leading to abdominal distension and decreased bowel sounds. Patients with peritonitis typically develop severe abdominal pain and tenderness. The abdomen may become rigid or board-like, which occurs because the abdominal muscles tighten in response to inflammation and pain. This protective response is called guarding. Other symptoms may include nausea, vomiting, abdominal distension, fever, chills, and tachycardia. These symptoms indicate a serious inflammatory response occurring in the abdominal cavity. If infection spreads from the abdominal cavity into the bloodstream, the patient may develop sepsis, which is a life-threatening systemic infection. Sepsis can progress to septic shock, causing low blood pressure, confusion, organ dysfunction, and decreased circulation to vital organs. Without rapid treatment, these complications can become fatal, so early recognition and treatment are essential. Diagnosis of peritonitis involves history, physical examination, laboratory testing, and imaging studies. Laboratory tests often include a complete blood cell count, which frequently shows an elevated white blood cell count, indicating infection. Imaging studies such as a computed tomography scan of the abdomen help identify the underlying cause, such as a perforated organ, abscess, or accumulation of fluid in the abdominal cavity. In severe cases, blood cultures may also be obtained to identify bacteria responsible for infection. Treatment of peritonitis focuses on controlling infection, stabilizing the patient, and correcting the underlying cause. Patients usually receive broad-spectrum intravenous antibiotics to treat the infection. Intravenous fluids and electrolytes are also administered to restore circulation and maintain hydration. A nasogastric tube may be inserted to decompress the stomach and remove fluid or gas, which helps reduce abdominal distension. In many cases, surgery is required to repair the underlying problem, such as closing a perforation or removing infected tissue. Nursing care for patients with peritonitis requires frequent assessment and careful monitoring. Vital signs may need to be monitored as frequently as every 15 minutes during critical phases. Patients are usually positioned in the semi-Fowler position, which means the head of the bed is elevated. This position helps improve breathing, reduce abdominal pressure, and allow infected fluid to collect in the lower abdomen. Nurses should monitor bowel sounds, abdominal distension, pain levels, and return of intestinal motility. If the patient has a gastric tube, frequent oral care is necessary to maintain comfort and prevent dryness of the mouth. Because the abdomen is extremely tender, patients should be repositioned gently and moved carefully in the bed to avoid worsening pain. Malabsorption refers to a group of conditions in which the small intestine cannot properly absorb nutrients, water, vitamins, or minerals from food. Under normal circumstances, digestion breaks food down into small molecules that pass through the lining of the small intestine and enter the bloodstream. In malabsorption disorders, something interferes with this process. As a result, the body cannot obtain enough energy, protein, vitamins, and minerals needed for normal health. Over time, this can lead to nutritional deficiencies, gastrointestinal symptoms, and weight loss. Several conditions can cause malabsorption. One of the most common is celiac disease, also called celiac sprue. Celiac disease is an autoimmune disorder in which the body reacts abnormally to gluten, a protein found in wheat, barley, and rye. Another common cause is lactose intolerance, which occurs when the body lacks the enzyme lactase needed to digest lactose, the sugar found in milk and dairy products. Malabsorption can also occur when the pancreas cannot produce enough digestive enzymes, a condition known as pancreatic insufficiency. These enzymes are necessary to break down fats, proteins, and carbohydrates. In some cases, damage to the intestinal lining, such as chemotherapy-related mucosal injury, may temporarily reduce nutrient absorption. Celiac disease occurs when the immune system reacts to gluten, which is a protein found in wheat, barley, and rye. When a person with celiac disease consumes gluten, the immune response damages the villi of the small intestine. Villi are tiny finger-like projections that increase the surface area of the intestinal lining, allowing nutrients to be absorbed efficiently. When these structures become flattened or damaged, nutrient absorption decreases, leading to symptoms such as diarrhea, weight loss, and nutritional deficiencies. Lactose intolerance occurs when the body does not produce enough lactase, the enzyme needed to digest lactose found in dairy products. When lactose cannot be broken down, it remains in the intestine and draws water into the bowel. Bacteria in the intestine also ferment the lactose, producing gas. This process leads to symptoms such as bloating, gas, abdominal cramps, and diarrhea. Many patients improve when lactose-containing foods are reduced or eliminated from the diet. Malabsorption commonly causes diarrhea and nutritional deficiencies. Because nutrients are not absorbed properly, patients may experience weight loss, fatigue, and weakness. One important sign of fat malabsorption is steatorrhea. Steatorrhea refers to stools that contain excess fat. These stools are often bulky, pale, foul-smelling, frothy, and may float in the toilet. Patients may also develop symptoms related to vitamin deficiencies such as anemia, bone pain from vitamin D deficiency, or easy bruising from vitamin K deficiency. Diagnosis of malabsorption involves medical history, laboratory testing, imaging studies, and endoscopic evaluation. Blood tests may detect antibodies associated with celiac disease, such as tissue transglutaminase antibodies. Imaging studies may evaluate the structure of the gastrointestinal tract. An endoscopy with biopsy of the small intestine can confirm damage to the intestinal lining and is commonly used to diagnose celiac disease. Treatment of malabsorption focuses on addressing the underlying cause and correcting nutritional deficiencies. Patients with celiac disease must follow a lifelong gluten-free diet to prevent intestinal damage. Patients with lactose intolerance usually improve by limiting dairy products or using lactase enzyme supplements. Patients with pancreatic insufficiency may require pancreatic enzyme replacement therapy, which is taken with meals to aid digestion. Many patients also require vitamin and mineral supplementation. Nursing care for patients with malabsorption focuses on monitoring nutritional status and reinforcing dietary education. Nurses should monitor body weight, laboratory values, and symptoms of vitamin deficiencies. Patients must learn how to read food labels and identify hidden sources of gluten or lactose. Education and support are essential because many dietary changes must be maintained long-term or lifelong. Cancer of the colon, also called colorectal cancer, refers to cancer that develops in the large intestine or rectum. It is one of the most common cancers affecting adults in the United States and is the third most common malignancy in both males and females. Each year, more than 100,000 new cases of colon cancer are diagnosed. Despite its high prevalence, mortality rates have declined in recent decades. This improvement is largely due to better screening programs, earlier diagnosis, and advances in treatment. Colorectal cancer is considered one of the most preventable cancers because screening tests can detect precancerous polyps before they become malignant. The exact cause of colorectal cancer is not fully understood, but several risk factors increase the likelihood of developing the disease. Age is one of the most significant risk factors. Most cases occur in adults over age 50, although rates in younger adults have recently increased. Other risk factors include family history of colorectal cancer and chronic inflammatory bowel diseases such as ulcerative colitis. Lifestyle factors also contribute to risk. These include smoking, excessive alcohol consumption, obesity, physical inactivity, and diets high in red meat or saturated fat. Diets low in fiber, fruits, and vegetables may also increase risk. Most colorectal cancers are adenocarcinomas, meaning they arise from the glandular cells lining the colon. These cancers often begin as adenomatous polyps, which are abnormal growths that develop on the inner lining of the colon. Over time, genetic mutations can cause these polyps to become cancerous. Tumors may grow in different patterns. Polypoid tumors grow outward into the bowel lumen, while annular tumors grow around the bowel wall, narrowing the intestinal passage and sometimes causing obstruction. Cancer cells can spread locally or metastasize through the lymphatic system or bloodstream, commonly reaching organs such as the liver or lungs. Symptoms of colorectal cancer often develop gradually and may be subtle in early stages. Common symptoms include changes in bowel habits, such as persistent diarrhea or constipation. Patients may also notice blood in the stool or black tarry stools, which may indicate bleeding in the gastrointestinal tract. As tumors grow, stools may become narrow or ribbon-shaped due to narrowing of the bowel lumen. Other symptoms include abdominal pain, pressure in the lower abdomen, unexplained weight loss, and fatigue. Chronic bleeding from tumors may cause iron deficiency anemia, leading to weakness and tiredness. Screening plays a critical role in preventing colorectal cancer. Common screening tests include stool guaiac testing, fecal immunochemical testing, and stool DNA testing. These tests detect blood or abnormal DNA markers that may indicate cancer. The most important screening procedure is colonoscopy, which allows healthcare providers to directly visualize the colon and remove precancerous polyps during the procedure. Blood testing for carcinoembryonic antigen, or CEA, may also be performed. Although CEA is not specific for colon cancer, it can be useful for monitoring treatment response or detecting recurrence. The primary treatment for colorectal cancer is surgical removal of the tumor. If the tumor is localized, the surgeon may perform a hemicolectomy, which removes the affected portion of the colon. The remaining sections of the bowel are usually connected through a procedure called an anastomosis, allowing normal bowel function to continue. In some cases, a colostomy may be required. A colostomy creates an opening in the abdominal wall so stool can exit the body into a pouch. Sometimes this is temporary, but in certain cases, it may be permanent. Additional treatments may include chemotherapy, radiation therapy, or targeted drug therapy, depending on the stage and spread of the cancer. Nursing care for patients with colorectal cancer focuses on assessment, education, and emotional support. Nurses should assess bowel patterns, dietary habits, alcohol intake, tobacco use, and family history of colon cancer, which may indicate increased risk. Laboratory tests such as the complete blood cell count may reveal anemia, and elevated liver enzymes may suggest possible metastasis to the liver. Patients diagnosed with cancer often experience significant anxiety and fear, so clear communication and emotional support are essential. Nurses also provide preoperative teaching, postoperative care instructions, and ostomy education when needed. An ostomy is a surgically created opening called a stoma that brings part of the intestine to the surface of the abdomen. This allows stool to leave the body when the normal route through the rectum and anus is not available or needs time to heal. In a colostomy, a portion of the colon or large intestine is brought through the abdominal wall. In an ileostomy, the ileum, which is the last part of the small intestine, is brought to the abdominal wall. The stoma allows stool to exit the body into a collection pouch attached to the skin. Some ostomies are temporary, meaning the bowel will be reconnected later through a surgical join called an anastomosis once healing has occurred. Other ostomies are permanent, especially when the rectum or anus must be removed or when bowel function cannot be safely restored. Ostomy surgery may be performed for several medical conditions. Common reasons include colorectal cancer, inflammatory bowel disease, trauma, bowel obstruction, or congenital defects affecting the intestines. Colostomies can be classified based on the surgical technique used. An end colostomy, also called a single-barreled colostomy, has one stoma that passes stool. A loop colostomy brings a loop of bowel to the abdominal surface and is commonly used when the surgeon plans to reverse the ostomy later. A double-barreled colostomy creates two stomas. The proximal stoma passes stool, while the distal stoma usually drains mucus from the remaining section of bowel. The location of the colostomy affects the consistency of stool. An ascending colostomy, located in the beginning of the colon, produces liquid stool because water absorption has not yet occurred. A transverse colostomy usually produces soft or semi-formed stool and may empty unpredictably. A descending or sigmoid colostomy produces more formed stool, since most water has already been absorbed. Because of this, patients with a sigmoid colostomy often develop a more predictable elimination pattern. An ileostomy is created when the colon must be bypassed or removed. Because stool leaves the body before reaching the colon, it remains liquid to pasty and contains digestive enzymes. These enzymes can irritate the skin around the stoma, making proper skin protection and a well-fitting pouch very important. Patients with ileostomies are also at higher risk for dehydration and electrolyte imbalance because the colon normally absorbs large amounts of water and sodium. After intestinal surgery, nurses must closely monitor the patient's vital signs, pain level, bowel sounds, fluid intake and output, and hydration status. Following surgery, bowel function may be temporarily slowed due to postoperative ileus, which is reduced intestinal motility after surgery. An important sign of recovery is the passage of gas or stool through the rectum or stoma, which indicates that peristalsis has returned. Assessing the stoma is an essential nursing skill. A healthy stoma is usually pink to red, moist, and slightly swollen, especially shortly after surgery. A stoma that appears dark, dry, pale, or dusky may indicate compromised blood supply and should be reported immediately. Nurses should also monitor stoma output, pouch fit, and the condition of the skin around the stoma. Complications may include skin irritation, bleeding, prolapse, retraction, or blockage. Patient teaching is a critical part of ostomy care. Patients must learn how to empty and change the pouch. They're going to want to change the appliance about every 2-3 days, protect the skin around the stoma, and monitor the stoma for signs of complications. They should also be taught to recognize signs of dehydration, especially with ileostomies. Psychological adjustment is also important. Many patients worry about body image, odor, leakage, social situations, and independence. Nurses should provide reassurance and education that most people can return to normal activities, work, and relationships with time and practice. Referral to a wound, ostomy, and continence nurse, often called a WOC nurse, provides specialized support and education for patients both in the hospital and after discharge. Careful observation of the stoma is one of the most important nursing responsibilities after ostomy surgery. A healthy stoma normally appears pink or deep red in color, which indicates that the tissue has an adequate blood supply. The stoma should look similar to the mucous membrane inside the mouth, meaning it should be moist and smooth. During the normal healing process, the stoma may shrink slightly and become somewhat less swollen, which is expected as post-operative swelling decreases. Regular assessment of the stoma helps nurses detect complications early and protect the patient from infection or tissue damage. When inspecting the stoma, the nurse should assess for changes in color, bleeding, swelling, and moisture. A small amount of bleeding around the stoma can occur because the tissue contains many small blood vessels and is easily irritated. However, excessive bleeding should be reported immediately to the healthcare provider. Mild swelling or edema is also expected shortly after surgery due to surgical manipulation of the bowel. Certain changes in the stoma require immediate medical attention. If the stoma appears dark purple, bluish, or black, this may indicate impaired blood flow or tissue necrosis. These findings may represent a surgical emergency and must be reported right away. Nurses should also monitor for excessive bleeding or severe swelling, which may indicate complications with the stoma or surrounding tissues. The peristomal skin, which is the skin surrounding the stoma, must be carefully monitored. Healthy peristomal skin should be dry, intact, and similar to the surrounding abdominal skin. If stool leaks onto the skin, irritation or breakdown may occur. This is particularly important with ileostomies because the stool contains digestive enzymes that can quickly damage the skin. Maintaining a properly fitted ostomy pouching system is essential for protecting the skin. Proper fitting of the ostomy appliance is essential for protecting the stoma and surrounding skin. The opening of the pouching system should be approximately 1/8 inch larger than the stoma. This allows enough space for the stoma without placing pressure on the tissue. If the opening is too tight, it may cause pressure, swelling, or reduce blood flow. If it is too loose, stool may leak onto the skin, leading to irritation and skin breakdown. Care of an ileostomy requires special attention because the output is continuous and more liquid. For this reason, a surgical dressing should never be placed directly over an ileostoma, since stool and digestive enzymes constantly drain from the opening. These enzymes can be highly irritating to the skin, so proper pouching and skin protection are essential. A sudden decrease in ileostomy output, especially when accompanied by abdominal cramping or distension, may indicate an intestinal obstruction. This condition requires immediate medical evaluation because untreated obstruction can cause the intestine to become distended and may lead to bowel rupture or perforation. Nurses must report these symptoms to the surgeon immediately. Patient education is an essential part of ostomy care. Patients must learn how to care for the stoma, protect the surrounding skin, and manage the ostomy appliance. Older adults may have difficulty managing ostomy care due to poor vision, arthritis, or decreased hand dexterity. In these situations, nurses should also teach family members or caregivers how to assist. Providing large print educational materials and clear instructions can help patients safely manage their ostomy care at home. Care of the stoma is an essential part of post-operative nursing management for patients who have undergone ostomy surgery. The stoma is the surgically created opening of the intestine through the abdominal wall that allows stool to exit the body. A healthy stoma normally appears pink to deep red, which indicates adequate blood supply. The tissue should resemble the mucous membrane inside the mouth, meaning it should be moist and healthy in appearance. During the healing process, the stoma may gradually decrease in size and become slightly less intensely colored, which is considered a normal part of recovery. When assessing the stoma, nurses should carefully observe the color, moisture, swelling, and presence of bleeding. Because the stoma contains many small blood vessels, minor bleeding may occur during cleaning or when the pouching system is changed. However, bleeding should remain minimal and temporary. Mild swelling, also called edema, is expected shortly after surgery due to surgical manipulation and inflammation. Certain findings during stoma assessment indicate serious complications and must be reported immediately. If the stoma becomes dark purple, bluish, or black, this may indicate impaired blood supply or tissue necrosis. This is a medical emergency and requires immediate evaluation. Persistent bleeding or severe swelling may also indicate complications that require prompt medical attention. Several types of ostomy appliances are available to collect fecal output. In a one-piece system, the skin barrier and pouch are attached together as one unit. In a two-piece system, the skin barrier remains attached to the skin while the pouch can be removed and replaced separately. This design can help reduce skin irritation and allow easier visualization of the stoma during care. The best appliance is one that fits securely, seals well around the stoma, and conforms to the patient's abdominal shape to prevent leakage. Fecal output from a colostomy does not usually occur immediately after surgery. Patients often receive bowel preparation before surgery, may develop post-operative ileus, and typically follow a clear liquid diet during the early post-operative period. Because of these factors, stool output may not begin for 2 to 4 days after surgery, which is expected. Nurses should monitor for the return of peristalsis and bowel sounds. Accurate measurement of intake and output, often abbreviated as I&O or INO, is extremely important after ostomy surgery. Monitoring I&O helps healthcare providers determine whether the patient is maintaining adequate fluid balance, meaning that the amount of fluid entering the body is approximately equal to the amount leaving the body. For patients with an ostomy, especially those with an ileostomy, stool output can contain large amounts of fluid. Because of this, monitoring fluid loss through the stoma is essential for preventing dehydration and electrolyte imbalance. For ostomy patients, the amount of fecal output is usually measured every 8 hours. This measurement is particularly important when the stool is liquid, which is common with ileostomies and may occur early after colostomy surgery. Liquid stool contains significant amounts of water and electrolytes, including sodium and potassium, which are necessary for normal body function. Monitoring these losses helps healthcare providers evaluate hydration status and electrolyte balance. Once the patient's condition stabilizes and hydration and nutrition are normal, routine Y&O measurements may eventually be discontinued. Unlike colostomies, ileostomies are generally not irrigated. This is because ileostomy output is continuous, and irrigation could interfere with normal intestinal function. In rare cases, irrigation may be performed if the stoma becomes blocked by undigested food particles. However, this procedure should only be done by a trained healthcare professional, such as an enterostomal therapist or wound, ostomy, and continence nurse. Some patients receive a continent ileostomy, commonly called a cock pouch. In this procedure, a pouch is created inside the abdomen using a portion of the small intestine. During the early post-operative period, a drainage tube allows intestinal contents to drain continuously while the pouch heals. After healing begins, patients are taught how to insert a catheter into the pouch to drain intestinal contents. Over time, the pouch increases in capacity and drainage becomes less frequent. Patients with a sigmoid colostomy often develop a more predictable bowel pattern because stool in this portion of the colon is usually more formed. These patients may perform colostomy irrigation, which involves introducing water into the colon through the stoma to stimulate bowel evacuation at a regular time. The goal is to establish a predictable bowel pattern, giving the patient greater control over elimination. During colostomy irrigation, a cone-tipped catheter is connected to a bag containing approximately 500 milliliters of warm tap water. The irrigation bag is placed 18 to 20 inches above the stoma, so water flows into the colon by gravity. An irrigation sleeve directs the drainage into the toilet. The cone tip is gently inserted into the stoma and water is infused slowly to prevent cramping and abdominal distension. After the water is infused, stool and water drain through the sleeve into the toilet. The primary goal of colostomy irrigation is to help the patient establish a regular pattern of bowel elimination. When irrigation successfully produces predictable bowel movements, some patients may be able to wear a stoma cap, which is a small covering placed over the stoma instead of a large drainage pouch. However, not all patients choose irrigation. Those who do not irrigate typically wear a drainable ostomy pouch to collect stool continuously. Patients who undergo ostomy surgery frequently experience significant emotional and psychological adjustments. Many patients go through the stages of grief and loss, which commonly include denial, anger, bargaining, depression, and acceptance. This reaction is normal because an ostomy represents a major change in body function and body image. For many patients, the presence of a stoma and an external collection device can feel overwhelming at first. As nurses, our attitude toward the patient and the ostomy plays a critical role in shaping how the patient adapts to these changes. When nurses demonstrate a calm, respectful, and matter-of-fact approach to stoma care, patients are more likely to develop confidence and acceptance of their new condition. Although managing body waste may seem uncomfortable to some individuals, nurses should approach ostomy care professionally and efficiently. A calm and non-judgmental approach helps reduce embarrassment and anxiety for the patient. Patients often observe the nurse's behavior and attitudes closely. If the nurse appears uncomfortable or hesitant, the patient may develop increased anxiety about self-care or body image. Encouraging social interaction and support is an important part of the patient's recovery and long-term adjustment. Support groups can be extremely beneficial for ostomy patients. Speaking with another individual who has successfully adapted to life with an ostomy can help patients see that a full and active life is still possible. Once the patient's post-operative pain is well controlled, arrangements may be made for them to meet with a peer support volunteer who has adjusted well to living with an ostomy. These visits allow patients to ask questions, discuss concerns, and learn practical coping strategies. Typically, these visits require an order from the healthcare provider to ensure proper coordination of care. Patients should also be encouraged to express their concerns openly. Many patients worry about practical issues such as odor, leakage of stool, and noises from passing intestinal gas, which is known as flatus. These concerns can create anxiety about returning to normal social activities, work, and relationships. Nurses can help patients explore lifestyle adjustments and practical solutions that improve confidence and independence. For example, some patients with a colostomy may benefit from using a stoma cap or a stoma patch, which is a small absorbent device placed directly over the stoma. A stoma cap can absorb small amounts of mucus but cannot collect stool or large amounts of fluid. Because of this limitation, colostomy irrigation must be performed immediately before applying the cap. When used appropriately, a stoma cap may be helpful during certain activities such as sports participation or sexual intimacy, allowing patients greater comfort and confidence. Concerns about sexuality and intimate relationships are also common for individuals living with an ostomy. Patients may worry about physical attractiveness, partner acceptance, or the potential for leakage or odor during intimacy. These concerns should be addressed openly and respectfully. Nurses should reassure patients that these concerns are common and encourage open communication with their partner. Including the patient's sexual partner in education and discussions can help both individuals understand how to manage the ostomy during intimacy and reduce anxiety. An enterostomal therapist, also known as a wound, ostomy, and continence nurse, WOC nurse, can provide additional guidance and resources for patients experiencing concerns related to sexuality and body image. While many patients eventually adapt successfully to living with an ostomy, some individuals may struggle with prolonged emotional distress. Signs that additional support may be needed include persistent depression, inability to accept body image changes, withdrawal from social activities, or prolonged dysfunctional grieving. In these situations, referral to a mental health professional or counselor may be appropriate. Professional counseling can help patients develop coping strategies, address emotional challenges, and improve overall quality of life. Ultimately, the nurse's role includes providing emotional support, education, reassurance, and encouragement throughout the patient's adjustment process. By fostering open communication and helping patients build confidence in their ability to manage ostomy care, nurses play an essential role in supporting both the physical and psychological recovery of ostomy patients. Patient education is a very important part of ostomy care because the patient will eventually be responsible for managing their ostomy independently at home. Education should begin after the patient understands the basic physiology of the ostomy, which means understanding how the intestinal contents now exit the body through the stoma instead of through the rectum. Patients must also learn how to care for the stoma, the surrounding skin, and the ostomy appliance. Once those basic skills are understood, additional teaching focuses on controlling odor, managing diet, preventing complications, and maintaining overall health. One of the most common concerns patients have after ostomy surgery is odor control. It is important to explain to patients that some odor is normal when the ostomy pouch is emptied or changed. This is similar to the odor that occurs with a normal bowel movement. Practicing good hygiene and properly sealing the pouching system will help minimize odor. Reassuring patients that odor can be managed effectively helps reduce anxiety and improves confidence with ostomy care. Dietary choices can significantly affect both odor and gas production. Certain foods are known to increase intestinal gas or produce strong odors. Foods commonly associated with odor include eggs, fish, garlic, raw onions, cucumbers, radishes, sauerkraut, broccoli, cabbage, cauliflower, asparagus, dairy products, beans, and soy products. Other foods such as corn, spices, and chewing gum may increase gas production. Eating quickly, swallowing excess air, or failing to chew food thoroughly may also increase gas in the intestinal tract. In addition, carbonated beverages and alcoholic beverages can contribute to gas buildup in the ostomy pouch. Gas produced in the intestine travels through the stoma and accumulates in the ostomy pouch. When gas builds up, the pouch may expand or inflate. Releasing the gas from the pouch is commonly called burping the bag. This can be done by opening the lower end of the pouch and gently pressing on the sides to allow gas to escape. If the patient is using a two-piece ostomy system, gas may also be released by slightly separating the pouch from the flange or barrier at the top and then reattaching it after the gas is released. If gas is not released, pressure inside the pouch may increase enough to cause the seal between the appliance and the skin to loosen, which may lead to leakage. Several products are available to help reduce odor and gas buildup. Some ostomy pouches contain charcoal filters that allow gas to escape slowly while reducing odor. Deodorizing sprays, drops, or tablets may also be placed inside the pouch to help control odor. In addition, some patients use a vent device, which is a small attachment that allows gas to be released easily without removing the pouch. Patients with a colostomy usually return to a regular diet gradually after surgery. However, patients with an ileostomy must be especially careful with dietary choices because the colon, which normally absorbs water and helps regulate stool consistency, is bypassed. For this reason, ileostomy patients have a greater risk for dehydration, electrolyte imbalance, and intestinal blockage. Education for ileostomy patients focuses on preventing intestinal blockage. Patients are usually instructed to eat 6 small meals per day rather than a few large meals, especially during the healing period. Foods should be soft initially, and patients should chew food very thoroughly before swallowing. New foods should be introduced gradually to determine how the digestive system tolerates them. Patients should also drink more than 8 cups of fluid per day to replace fluids lost through the ostomy. Certain foods may increase the risk of intestinal blockage in ileostomy patients. Examples include dried fruits, popcorn, nuts, seeds, foods with casings such as sausages, apple peels, oranges, pineapple, raw cabbage, celery, Chinese vegetables, coconut, and mushrooms. These foods contain fibers or tough materials that may not digest completely and may become lodged near the stoma. Patients should also be taught what to do if they suspect a blockage of the ostomy. Symptoms may include abdominal cramping, swelling of the stoma, decreased or absent ostomy output, and nausea. If a blockage occurs, the patient may begin a liquid diet temporarily to reduce intestinal stress. Because swelling of the stoma may occur during blockage, the opening of the faceplate may need to be cut slightly larger than usual to prevent pressure on the stoma. Other measures include taking a warm bath to relax abdominal muscles, gently massaging the abdomen and area around the stoma, and trying different body positions such as a knee chest position to help move the blockage forward. Some providers may recommend oral digestive enzymes to help break down food. If the blockage does not resolve and stomal output stops for several hours, the patient must contact their healthcare provider or enterostomal nurse, also known as a wound, ostomy, and continence nurse, WOC nurse. If the provider cannot be reached, the patient should go to the emergency department and bring their ostomy supplies. Patients should be instructed not to attempt irrigation of the ileostomy and not to take laxatives, because these actions may worsen the obstruction. Medication absorption may also be affected in ileostomy patients. Because intestinal contents move quickly through the digestive tract, time-release medications and enteric-coated tablets may not dissolve completely before passing through the stoma. Patients should discuss medication options with their healthcare provider to ensure proper absorption. Adequate fluid intake remains extremely important for all ostomy patients to prevent dehydration and electrolyte imbalance. Education should emphasize the importance of drinking fluids regularly throughout the day. Patients should also be informed about available resources for additional support and education. Organizations such as the American Cancer Society, ACS, local ostomy support groups, and specialized nurses such as enterostomal therapists provide valuable education and emotional support. Enterostomal therapists are nurses who specialize in wound and ostomy care and often have advanced training and certification in this area. Finally, evaluation of patient education is essential before discharge. The patient should demonstrate the ability to perform ostomy care, recognize signs of complications, manage diet appropriately, and maintain hydration and electrolyte balance. The patient should also show evidence of psychological adjustment to body image changes. If learning goals are not met, the teaching plan should be revised, and additional education or support should be provided. Anorectal disorders are conditions that affect the anus and rectum, which are the final portions of the gastrointestinal system. One of the most common anorectal disorders is hemorrhoids. Hemorrhoids are swollen or dilated veins located in the rectal area. They develop when pressure increases within the veins of the rectum and anus, causing them to enlarge and become varicose. These enlarged veins may develop inside or outside the anal sphincter muscles, which leads to two different types of hemorrhoids. Hemorrhoids are classified into two main types, internal and external hemorrhoids. Internal hemorrhoids occur inside the anal sphincter, which is the muscle that controls the passage of stool. These hemorrhoids are usually not visible externally, but they may bleed during bowel movements. External hemorrhoids occur outside the anal sphincter. They are easier to see and feel and may appear as swollen projections around the anus. External hemorrhoids are often associated with pain, discomfort, or itching. Hemorrhoids usually develop because of venous congestion, which occurs when blood flow through the rectal veins becomes slowed or obstructed. One of the most common causes is chronic constipation. Repeated straining during bowel movements increases pressure in the rectal veins. Spending long periods sitting on the toilet can also increase venous pressure and contribute to hemorrhoid formation. Other risk factors include pregnancy, obesity, and prolonged sitting or standing, all of which increase pressure in the pelvic veins. Several medical conditions can also contribute to hemorrhoid formation by increasing abdominal or pelvic pressure. Examples include enlargement of the prostate gland, uterine fibroids, and rectal tumors, which can interfere with normal venous blood flow. Patients with chronic liver disease may develop hemorrhoids due to portal hypertension, which is increased pressure in the venous system that drains blood from the digestive organs. The most common symptoms of hemorrhoids include pain, itching, and rectal bleeding. Patients may notice bright red or dark red blood on the surface of the stool or on toilet tissue after a bowel movement. This occurs because the swollen veins are fragile and easily injured during defecation. External hemorrhoids may be more noticeable because they can be seen or felt around the anus, even though they may bleed less frequently than internal hemorrhoids. Hemorrhoids are usually diagnosed through a physical examination of the rectal area. If a patient reports rectal bleeding, healthcare providers may perform additional tests to rule out more serious conditions such as colorectal cancer or inflammatory bowel disease. Diagnostic procedures may include endoscopy, which uses a small scope to examine the anal canal, or flexible sigmoidoscopy, which allows visualization of the lower colon. Nurses must also assess whether patients are taking medications that affect blood clotting. Patients who take anticoagulant medications or antiplatelet medications may experience increased bleeding from hemorrhoids because these drugs reduce the blood's ability to clot. For this reason, reviewing the patient's medication history is an important part of assessment when rectal bleeding is present. Treatment for hemorrhoids often begins with conservative management aimed at reducing symptoms and preventing further irritation. One of the most important interventions is correcting constipation. Patients are encouraged to increase dietary fiber and fluid intake, which helps produce softer stools that pass more easily. Local treatments may include sitz baths, which involve soaking the anal area in warm water to reduce inflammation and discomfort. Topical medications such as local anesthetic ointments or hydrocortisone creams may also be used. In more severe cases, surgery may be required. This procedure is called a hemorrhoidectomy, which involves removal of the enlarged hemorrhoidal tissue. Hemorrhoidectomy may be performed using traditional surgical methods or specialized instruments such as lasers. Surgery is usually reserved for patients who do not respond to conservative treatment or minimally invasive procedures. Nursing care for hemorrhoids focuses on patient education and prevention of complications. Patients should be taught proper rectal hygiene, including gentle cleansing with warm water after bowel movements. Preventing constipation is essential, so nurses encourage a high-fiber diet and adequate fluid intake to promote regular bowel movements. After hemorrhoid surgery, pain management is a priority because the surgical area is extremely sensitive. Patients are often prescribed analgesics and stool softeners to reduce discomfort and make bowel movements easier. Sitz baths are commonly ordered 3 times daily to reduce swelling and improve comfort. Patients may sit on an air-filled or foam cushion, but donut-shaped cushions should be avoided because they increase pressure around the surgical area and may slow healing. A pilonidal sinus, often called a pilonidal cyst, is a condition that occurs in the sacrococcygeal region, which is the area near the tailbone at the top of the buttocks. The term pilonidal literally means nest of hair. Although it is commonly referred to as a cyst, it is actually a sinus tract under the skin that may have small openings on the surface rather than a true fluid-filled sac. This tract forms when hair and debris collect beneath the skin and cause irritation and inflammation. A pilonidal sinus usually develops when coarse or stiff hairs penetrate the skin in the crease between the buttocks. These hairs become trapped under the skin, and the body reacts to them as if they were a foreign object. This reaction leads to inflammation and infection, which causes the formation of a sinus tract or tunnel beneath the skin. Hair, skin debris, and bacteria may collect inside the tract, increasing irritation and the risk of infection. Several factors increase the risk of developing a pilonidal sinus. These include local trauma, poor hygiene, obesity, and excessive body hair. Individuals with thick or coarse hair are more susceptible because loose hairs can easily penetrate the skin. The condition is also more common in people who sit for long periods, such as drivers, office workers, or students, because constant pressure and friction in the buttock cleft encourage hair penetration into the skin. In some cases, a pilonidal sinus may remain asymptomatic, meaning the patient has no noticeable symptoms. However, when the sinus becomes infected, symptoms can develop quickly. Patients may experience pain, swelling, redness, and tenderness in the sacrococcygeal region near the tailbone. These symptoms often worsen when sitting or moving. When infection progresses, a pilonidal abscess may develop. An abscess is a localized pocket of pus caused by infection. Patients with an abscess may experience severe pain, especially when sitting, bending, or moving. If the abscess drains through the skin, the patient may notice purulent drainage, which is thick, pus-like fluid. Diagnosis of a pilonidal sinus is usually straightforward. Healthcare providers typically make the diagnosis based on the patient's history and physical examination. During examination, the provider may observe small pits or openings in the skin within the buttock cleft, along with swelling, redness, or drainage if infection is present. Treatment depends on the severity of symptoms. If infection or abscess formation occurs, the most common treatment is incision and drainage. During this procedure, the surgeon makes a small incision in the abscess to allow pus and debris to drain. Hair and necrotic tissue, meaning dead tissue, are also removed from the sinus tract to promote healing. This procedure is usually performed as an outpatient surgery, allowing the patient to return home the same day. It is important to understand that antibiotics alone cannot cure a pilonidal sinus. Although antibiotics may be prescribed when infection is present, they do not eliminate the sinus tract itself. For this reason, surgical drainage or removal of the tract is usually required when symptoms are severe or persistent. Preventive care is very important to reduce recurrence of pilonidal disease. Patients are encouraged to maintain good hygiene of the sacrococcygeal area, keeping the skin clean and dry. Regular hair removal, such as shaving or other hair removal methods, helps prevent loose hairs from penetrating the skin. Patients should also try to avoid prolonged pressure or sitting for long periods when possible. Nursing management focuses on pain control, wound care, infection prevention, and patient education. After surgical drainage, nurses monitor the wound for signs of infection, such as increased redness, swelling, warmth, or purulent drainage. Patients must also be taught proper wound care and hygiene practices at home, along with preventive measures such as hair removal and reducing pressure on the affected area. With proper treatment and prevention, most patients recover well, although recurrence can occur if hair and debris continue to accumulate in the area. An anorectal abscess is a localized infection that forms in the tissues around the anus or rectum. This infection results in a collection of pus in the affected tissue. The infection usually develops when bacteria enter the tissue through a break in the skin or mucous membrane, which is the moist lining of the rectum. Once bacteria enter the tissue, infection develops and pus accumulates, forming an abscess. One common cause of anorectal abscesses is constipation with hard stools. Passing hard stool can cause small tears in the delicate mucosal lining of the anal canal. These tears allow bacteria to enter the surrounding tissues. Once bacteria enter the tissue, infection develops and pus accumulates, leading to the formation of an abscess. An anal fistula is an abnormal tunnel or tract that forms between the anal canal and the skin near the anus. Fistulas commonly develop after an anorectal abscess fails to heal completely. The infection creates a tract that connects the internal infection site to the external skin. This tract becomes lined with inflamed tissue and may continue to drain infected material. Patients with anorectal abscesses or fistulas often experience significant discomfort. Common symptoms include pain around the anus, swelling, redness, and tenderness. Another common sign is purulent drainage, which is thick, pus-like fluid draining from an opening in the skin near the anus. Pain is a common symptom for both anorectal abscesses and fistulas. The pain often becomes worse when sitting, coughing, or moving because pressure is placed on the infected tissue. In more severe infections, patients may also develop fever and increased tenderness in the affected area. In some patients, anorectal fistulas may be associated with Crohn's disease, which is a type of inflammatory bowel disease. Approximately half of patients with Crohn's disease may develop rectal fistulas during the course of the disease. For this reason, healthcare providers may suspect Crohn's disease if a patient with a fistula also experiences chronic diarrhea or other gastrointestinal symptoms. Diagnosis of anorectal abscesses and fistulas is usually based on the patient's history and physical examination. The healthcare provider will inspect the anal area for swelling, redness, drainage, or small openings in the skin that may indicate a fistula tract. In some cases, additional imaging studies may be used to determine the location and extent of the fistula tract. The primary treatment for an anorectal abscess is incision and drainage. During this procedure, the surgeon makes an incision in the abscess so that pus can drain, relieving pressure and allowing the infection to heal. If a fistula is present, surgical treatment is usually required. This procedure is called a fistulectomy, which involves removing the abnormal fistula tract. Nursing management focuses on pain control, infection prevention, hygiene, and patient education. Pain medications are often prescribed because the affected area is very sensitive. Preventing constipation is extremely important because straining during bowel movements can worsen symptoms and delay healing. Patient education is an important part of nursing care. Patients should be encouraged to increase fiber intake and fluid consumption to help prevent constipation. Regular sitz baths, which involve soaking the anal area in warm water, can help reduce inflammation, improve circulation, and relieve pain. Patients should also be instructed to report signs of infection, such as increased pain, fever, excessive drainage, or worsening swelling.